we are going to talk about some of the spinal cord injuries and see how we can apply the information which you have learned in terms of tracks and the spinal cord structure to spinal cord injuries. So we are going to discuss a number of syndromes which are associated with the spinal cord injuries, and we'll see how they are going to clinically appear. So you need to differentiate between the acute versus chronic injuries, and you need to differentiate between a complete versus incomplete spinal cord injury. So there could be a complete transaction and it could be part of the spinal cord damaging. So you need to differentiate between an acute problem which happened few hours back or a day back, and you need to differentiate between a chronic problem. People might come to you in your clinic with a chronic backache, and people might come to you that they were moving around and suddenly they have weakness in their legs and they cannot move their legs. So you need to differentiate between an acute injury and a chronic problem, and you need to differentiate between a complete damage of the spinal cord and an incomplete damage of the spinal cord. The terminologies which are usually used, we have plegia. Whenever the word plegia is used, it means a complete lesion or complete paralysis. When you use the word paresis, it means some strength in the muscles is preserved. Quadriplegia means all four limbs are involved. Paraplegia, usually the injury is in the thoracic and the lumbosacral part of the cord or chordae equina and affects both lower limbs. Okay, so usually when you have both lower limbs paralyzed, the injury is either in the thoracic, lumbosacral, or the chordae equina. Hemiplegia is half side of the body is paralyzed. This means the head and neck is also involved. So if it is head and neck also involved, then usually the injury is above the spinal cord and it is a stroke in the brain somewhere. Okay? So hemiplegia, usually the paralysis of half side of the body, usually a brain injury above the spinal cord, and it's usually a stroke. So how you are going to determine each segment of motor activity? For example, if you are looking at C5 segment of the spinal cord, it usually supplies the deltoid or the biceps muscles. So what you do is ask the patient to shrug the shoulder or abduct the shoulder and flexion of the elbows. So flexion of the elbows, abduction of shoulders is basically you are testing the C5 level of the spinal cord. When you ask the patient to cock up the wrist, you extend the wrist or cock up the wrist. This is cocking up the wrist. So this cocking up the wrist is C6. Okay. Triceps, if you ask the patient to extend the elbow against resistance, so extending the elbow against resistance is C7. Okay. So cocking up wrist is C6, extension of the elbows is C7, flexion of the elbows is C5, and if you go to the C8, you ask the patient to squeeze your hand, squeezing your hand. So this is flexor digitorum profundus, and your squeezing the hand is C8. If you're looking at intrinsic muscles of the hand, you ask the patient to abduct and adduct the fingers. So that is the small muscles of the hand, and that is at the level of T1. So this is from C5 to T1, and for testing the lumbar segments, you can ask the patient to flex the hip, straighten the knee, dorsiflex the foot, dorsiflex the big toe, and plantarflex the foot. So these are T1 to S1. And you can see the number, the names of the muscles which you are testing. Now, when you are testing the strength, you grade the strength of the muscles from 0 to 5. There might be no contraction, which is 0. If there is a flicker of contraction, this is 1. If you negate the gravity and you can be able to contract the muscle, then it is 2. And if you are able to perform a movement against gravity, then it is 3. And then you have 4, which is the movement against resistance. So slight resistance, 4 minus, moderate resistance, 4, strong resistance, 4 plus, and normal strength is 5. So this is how you grade the strength of the muscles. And these are the dermatomes for sensory input. So when you are trying to test for sensory input, you usually use, a pinprick, or you use a cotton swab, or you use a tuning fork, but you need to know where to place them so that you would know which dermatome you are actually testing. For example, shoulder is C4, C5, thumb is C6, middle finger is C7, little finger is C8, your nipples are T4, xiphoid process is T6, umbilicus is T10, just above patella is L3, medial malleolus is L4, great toe is L5, S1 is the lateral malleolus, and S4, S5 is the perianal area. So these are the areas out of which, if you remember few of them, the main landmarks, and you know which dermatome it is, you can test which area of the spinal cord could have been damaged. Usually you're using a cotton swab, a pinprick, and a tuning fork. So you are basically using pinprick for pain as well as fine touch, cotton swab for crude touch, and vibration you are testing with the tuning fork. So these are the levels, how you determine the level. These are the reflexes. So you have bicep reflex, which reflex is representing C5. The brachioradialis reflex is basically C6, and the tricep reflex, which is the extensor reflex, is C7. Patellar reflex is L3, L4, and your Achilles tendon reflex is S1. In pathologies, in upper motor neuron, you know that there is a Babinski sign, and you might have clonus. Clonus means that if you tap, normally your reflex is 1, but if muscle gets into contraction and it continues to contract, then you have a clonus. So clonus is a hyper-exaggerated deep tendon reflex. So what is and how you determine the level of injury? So what you do is you identify the motor level, the last level where you have at least 3 out of 5 power, and the last sensory level where your sensations are preserved. So when you're doing the neurological examination, you're going from down up, and you see the last level where you are able to have a motor function 3 out of 5 and sensory function preserved. Okay, whichever the sensations are: pain, temperature, touch, two-touch discrimination, vibration, pressure. All these sensations you want to test, and you want to see what is the last level where these sensations are preserved, and what is the last level where your motor activity is 3 out of 5 at least. Then you do the radiological examination to identify the level of fracture on plain X-ray, CT scan, and MRI. The best modality is MRI. It would give you the more detailed account of any injury. Spine level does not correspond to the spinal cord level below the cervical region of the spinal cord. So we have already said that the vertebral levels are not going to correspond with the segments. And we have already given you a formula how would you find a vertebral fracture, and then you can correspond it to the spinal levels. Okay? We talked about the spinal shock, but we didn't talk about the neurogenic shock. So neurogenic shock, there is a difference between neurogenic shock and spinal shock. Neurogenic shock is usually seen in the cervical injuries, and it happens due to the interruption of the sympathetic input from the hypothalamus to the cardiovascular centers. The hallmark of the neurogenic shock is hypotension, loss of sympathetic input, and is associated with bradycardia due to inability to convey the information to the vasomotor centers in the spinal cord. So your autonomic fibers, which are coming from the hypothalamus, especially the sympathetic fibers, they are passing through the lateral column of the spinal cord. If you have a cervical injury of the spinal cord, you know that your sympathetic system is thoracolumbar. So the main cell bodies of the sympathetic system are present in the thoracic and the lumbar part of the spinal cord. So if you have a cervical cord injury and these fibers are interrupted, what would happen is that the thoracic and the lumbar part of the cord, which is responsible for the sympathetic nervous system, will not receive its inputs. So there would be hypotension and bradycardia. So the hallmark of a neurogenic shock is bradycardia and hypotension, and it happens in the cervical cord injuries, okay, because of the interruption of the sympathetic fibers. So what is the difference between the neurogenic shock and spinal shock? Spinal shock mainly is a loss of reflexes, it is flaccid type of paralysis, and neurogenic shock is mainly hypotension and bradycardia due to loss of sympathetic tone. Okay, so now this is a scenario. You have a 25-year-old white male fell off the roof 20 feet high and had to be intubated at the scene by the emergency medical services. Consciousness regained shortly thereafter, could not move arms and legs, could close and open eyes to command, not able to breathe by himself, totally dependent on mechanical ventilation. So, what is happening is it's a higher cervical cord injury, and it's between C3 to C5, and we said that C3 to C5 supplies the phrenic nerve nucleus, which supplies the diaphragm. So the guy is still able to move his eyes because the brainstem is intact. There is no problem with the brainstem. He can even see people, he can move his facial muscles, but he cannot move his limbs because all the supply to his limbs are going to come at the level of the cervical level of the spinal cord. So if you have a complete transaction at C3, C5, you would not be able to move your limbs, and because your diaphragm is paralyzed, you need help in terms of the mechanical ventilation. So motor and sensory deficits involve the entire arms and legs, dependent on mechanical ventilation for breathing. Diaphragm is innervated by C3 and C5 segments of the spinal cord. Okay, this is another scenario. You have a 19-year-old white male. There is a diving accident in a shallow water. No loss of consciousness. Could not understand why he could not move his legs, forearms and hands. He could shrug the shoulders and elevate the arms. Blood pressure is 75/40. Heart rate is 54. Had difficulties breathing and required intubation a few hours after the accident. Neurogenic shock because of the hypotension and the heart rate going down. So this is again a cervical level injury because it is going to interrupt the sympathetic fibers, resulting in the neurogenic shock. And then part of he can shrug the shoulders and elevate the arms. This means that C5 is intact. So it's somewhere in the lower cervical segment that the injury is there. So if you see varying degrees of diaphragm dysfunction, usually need ventilation in acute phase, shock, but it's usually an injury between C5, C6. Yes? Okay? Okay, now we are coming to the most important part of this session. And these are some of the syndromes where we have incomplete damage to the spinal cord. So you don't have a complete transaction, there is a incomplete damage to the spinal cord, and you need to know all these 5 syndromes. These are most heavily tested later on in the exams also. In our exams as well as when you go outside, you would find that these 5 syndromes are heavily tested. The first one is the central cord syndrome. This central cord syndrome usually happens in old people and in whiplash injuries, when your neck is hyperextended. Like when you are driving and somebody struck you from the back and you have this type of whiplash type of injury. What happens in the whiplash type of injury? Typically in older patient, hyperextension in the injury in the neck. What is happening is that your spinal cord is compressed because there is a very strong ligament at the back of the spinal cord, which is called ligamentum flavum. So spinal cord is compressed between the ligamentum flavum and the body of the vertebra. So if the spinal cord is going to be compressed, the central part of the spinal cord is the one which is going to be affected. So if we see here, you have the spinal cord and this is the part of the spinal cord which is going to be affected because there is a ligamentum flavum here, very strong ligamentum flavum, and there is a body of the vertebra here, body of vertebra. So between these two things, it is going to get compressed. So this area of the spinal cord, which is around the central canal, is going to be affected. Now, if this is going to be affected, there are 2 tracts in the lateral white column, one sensory and one motor. Two important tracts. Which are those 2 important tracts? Okay, so you have lateral corticospinal and you have lateral spinothalamic. These are the 2 tracts which are there. Okay. Now we also said that there is lamellation in these 2 tracts. That means the upper limb is lying medially and lower limb is lying laterally. So if this is a whiplash injury at a cervical segment C4 or C5, which fibers are going to be affected first? The upper limb fibers, because they are medially located. Lower limb fibers are located laterally. So those fibers which are located medially would be affected. So you would have below the level of the lesion, you would have loss of pain and temperature bilaterally in the lower limbs, in the upper limbs, but your lower limbs would be spared. And bilaterally, you would have hyperreflexia in the upper limb, but your lower limbs will be spared because the corticospinal tract and the spinothalamic tract have lamellation. So medial fibers are affected, lateral fibers are spared. So there is a characteristic sacral sparing. Characteristic sparing of lower limb and sacrum. So characteristic lower limb and sacral sparing because those fibers are laterally located. So when you have central cord syndrome, below the level of the lesion, you would have sparing. in the lower limbs, as well as both for pain and temperature, as well as for the hyperreflexia. But if you see the upper limbs would have loss of pain and temperature, and you would also have spastic type of paralysis, hyperreflexia in the upper limbs. So in central cord syndrome, there is a characteristic lower limb sparing. Only the upper limbs bilaterally would be affected. There would be hyperreflexia, spastic type of paralysis, and loss of pain and temperature. Okay? So if you see this, so it is associated with fracture and dislocation and compression fractures. More centrally situated cervical tracts tend to be more involved, hence flaccid weakness of arms more than legs. Perineal sensation and lower extremity movements and sensation may be preserved. And if you see this, this is the type of injury which is happening here. You have ligamentum flavum at the back, and you have the bodies here. So that central part of the cord is basically compressed. Yes?
We will have flaccid type paralysis or spastic?
At this segment where you have the cord compression, yeah, and below the segment you have the spastic type of paralysis, but it would be more in the upper limb, and bilaterally lower limbs would be spared, because there is not going to be any effect on the lower limb because the fibers are located laterally. Then we are coming to the another syndrome which is called the anterior cord syndrome. Now anterior cord syndrome usually happen because of the disruption of the blood supply. And if you remember, it can happen because of the fracture and the protrusion of the disc posteriorly, but mainly the anterior cord syndrome happens because of the disruption of the blood supply. And if you remember, the blood supply for the anterior 2/3 of the spinal cord is by anterior spinal artery. So if the disruption of the blood supply is there, and we also said that this anterior 2/3 is also supplied by intersegmental arteries. So if there is a disruption of the intersegmental arteries because of a fracture of the vertebra or an injury in the spine, the usually anterior spinal artery is unable to, give the full supply to the anterior 2/3 of the spinal cord. So if there is an ischemia of the anterior 2/3 of the spinal cord, there would be damage to the anterior 2/3 of the spinal cord. Now in the anterior 2/3 of the spinal cord, you have the anterior gray matter. Okay, so this anterior gray matter. So at the level of injury, at the level where you have the anterior cord syndrome, bilaterally you would have flaccid type of paralysis. Okay, and below the level of injury, because corticospinal of both sides are gone, you have spastic type of paralysis. Below, this is at the level below the level of injury, you would have bilateral spastic type of paralysis. Okay? Everybody is clear with this? Now, you also have the spinothalamic pathway gone. So bilaterally below the level of injury, and at the level and below the level of injury, you would lose pain and temperature. What is left? Posterior column. Does the dorsal column is affected? No. So your two-touch discrimination, vibration, and proprioception would be preserved. So if your two-touch discrimination, vibration are preserved, and bilaterally at and below the level of the lesion, you are losing pain and temperature, and at the level you have flaccid type of paralysis bilaterally, and below the level of the lesion you have bilateral spastic type of paralysis. This is anterior cord syndrome. It's called anterior cord syndrome. Okay? Clear? Yes, go ahead.
Cerebellum tract will be damaged, isn't it?
Yes.
So you will have ataxia.
Usually not. Clinically, they would present at the levels you would have flaccid type of paralysis below the level of lesion, you have spastic type of paralysis, pain and temperature below the level of the lesion, and at the level of the lesion would be lost bilaterally, but two-touch discrimination, vibration, proprioception would be preserved.
Can we assume that the anterior right column might be affected?
Anterior white column would be affected.
So we lose root touch and pressure. So we can assume we will lose root touch and pressure. Right?
You can assume that true touch and pressure would be lost also. But this is all theoretical. Clinically, what you would see, pain and temperature loss, flaccid type of paralysis at the level, spastic type of paralysis below the level of lesion, and you would have preservation of proprioception, conscious proprioception, two-touch discrimination, and vibration. Okay? So, it could be the anterior cord syndrome could be flexion and rotation injuries, anterior dislocation, compression fractures of the vertebral body, but the most important one is the disruption of the blood supply to the anterior two-thirds of the cord. Corticospinal and spinal thalamic tracts are damaged either by direct trauma or ischemia of the blood supply, the anterior spinal artery. Clinically, loss of power, decrease in pain and sensations below the lesion, dorsal column remains intact. So that is the feature of the anterior cord syndrome. You can also have a posterior cord syndrome where only the posterior column is affected. Usually you would have ataxic gait. This happens mainly in a condition which is called tapes dorsalis in syphilis. So in syphilis you have only the dorsal column affected and you have ataxic gait. So tapes dorsalis is one of the conditions where you can have the posterior cord syndrome, or where you have only the posterior or dorsal column of the spinal cord affected.
Doctor?
Yes?
Why will we have ataxic gait?
Because of proprioception. Conscious proprioception is going through dorsal column tracts. So if you are unable to feel anything in your heel or your feet, that when you are touching the ground, if you cannot feel that consciously, what you would do? You would have ataxia because of that. Yes. So next we are coming, the most important and the most difficult one is the Brown's cord syndrome, which is the hemisection of the spinal cord. Now in the hemisection of the spinal cord, there are different things which you would see at the level of injury and below the level of injury. So this is the spinal cord again. And we have the gray matter. And we have damage half side of the cord. So this is the right side of the cord which is affected. Left side is intact. The level is T4 level of spinal cord. Okay? Your half side of the spinal cord is cut. This happens usually in gunshot injuries, penetrating injuries like stab wounds. You can have half side of the cord completely transected or partly transected. Now first we would look at the level of injury. What would happen at the level of injury, and then we will go to below the level of injury. In terms of the motor system, at the level of injury, if you damage the anterior gray horn cells, so you would have ipsilateral flaccid type of paralysis. Okay? Your dorsal root which is entering into the spinal cord at the level of injury is also going to be damaged. So sensory, you would have ipsilateral band anesthesia, ipsilateral band anesthesia. All sensations are lost in the dermatome where the injury has happened, ipsilaterally. There would be band anesthesia because your dorsal root which is entering there is also cut. Then we are going to below the level of injury. Okay, below the level of injury. Now, in terms of the motor system, the corticospinal tract,
The same side.
corticospinal tract is going to be cut. But you know that corticospinal tract crosses where? At the junction of medulla to spinal cord. So it has already crossed. So you would have ipsilateral spastic type of paralysis. Spastic type of paralysis below the level of injury because of cutting of the corticospinal tract. This corticospinal hair is going to be cut. This is representing the same side of the body because it has already crossed at the level of medulla. So what you would have, ipsilateral spastic type of paralysis. In terms of sensory,
Contralateral penetration and ipsilateral
so
to touch.
spinothalamic is cut. So spinothalamic here is representing the
Left
contralateral side of the body. This side of the body. So you would have contralateral pain and temperature loss. Okay? In terms of the dorsal column, this is representing the ipsilateral side. So you would lose ipsilateral vibration, two-touch discrimination, vibration, and conscious proprioception. So this is going to happen below the level of lesion. So anytime at the level of the lesion you have flaccid paralysis and ipsilateral band anesthesia, and below the level of the lesion you have ipsilateral spastic type of paralysis, and in terms of sensory loss, contralateral pain and temperature loss, and ipsilateral two-touch discrimination and vibration loss, you know that this is a Brown's cord syndrome, and this is hemisection of the spinal cord. So it happens due to penetrating injuries like stab wounds, gunshot wounds, fractures of the lateral mass of the vertebra. So if there is the lateral side of the vertebra is fractured, it's going to compress the one half of the spinal cord. Paralysis on the affected side because of the corticospinal tract. Loss of proprioception and fine discrimination loss on the same side also. This is because of the dorsal column. And pain and temperature loss on the opposite side below the lesion. This is because of the spinothalamic pathway. These are the features. So on the contralateral side, you would lose pain and temperature caudal to the lesion, and this is because of the interruption of the spinothalamic pathway. On the ipsilateral side, these are the issues, and these are the anatomical basis of the Brown's cord syndrome. Sometimes in Brown's cord syndrome, you might also have, loss of sweating caudal to the lesion if the lesion is in the cervical segments of the spinal cord, because the sympathetic fibers would be interrupted also. So you would have loss of hydration over the face, and you start to think, oh, this is because it is involved in the face, you probably have a brainstem lesion. It is not a brainstem lesion, it is a Horner syndrome because of the interruption of the sympathetic fibers. So you would have dilatation of the pupil, you would have anhydration, that means sweating would be lost on the half side of the face, and that is because of the interruption of the sympathetic fibers. So don't get confused if somebody tricks you up with Brown's cord syndrome and give you the features of the Horner syndrome, because Horner syndrome can happen because of the interruption of the sympathetic fibers.
This Horner syndrome only happens in lesions above T1.
Yes, because the cervical segment of the spinal cord, it would be somewhere in a lesion in the cervical segment of the spinal cord when you would have Horner syndrome associated with Brown's cord syndrome. Okay? Yes, go ahead.
So the Horner syndrome causing the constriction of the pupil.
The Horner syndrome, yeah, sympathetic fibers are going to be gone, so parasympathetic activity will be increased, so constriction of the pupil. The last thing, which is the chorda equina syndrome, and the chorda equina syndrome usually happens because of the bony compression or disc protrusion, which happens in the lumbar and sacral region. Usually people come with, they call in the local language, slip disc. You know, my disc has slipped. So this is basically chorda equina syndrome, where your nucleus pulposus, or the disc between the vertebra in the lumbar or sacral region, protrudes out, and because there is no spinal cord below L1 and L2, what is there is chorda equina. So this disc, if it is going to protrude out, it is going to compress what? Chorda equina. So clinically, non-specific symptoms like backache. So somebody, they would have different types depending upon how much the protrusion is and how many nerves are compressing. They would give you different types of features. You know, back pain radiating to the back of the leg all the way down, like sciatica. You know, they might give you a complete, you know, severe pain radiating from their back into the buttocks and going down into the legs, depending upon how many nerves are basically being compressed, okay, and how big is the protrusion. Now, because there are also within these fibers, the fibers which are supplying the bladder and bowel, the lower part of your bowel, the rectum and the urinary bladder, are supplied by the sacral segments of the spinal cord, and the nerves are passing with these chorda equina nerves. So if there is compression to that, there might be bowel dysfunction or bladder dysfunction. When you have leg numbness or decreased sensation in the leg bilaterally, and weakness with a saddle type of paresthesia, that means the paresthesia of your perineum, because saddle type of paresthesia is when you sit on a horse, that area which it's touching the saddle, that's the saddle area, the perineal area. If you have loss of sensation in that area, and you have weakness in both lower limbs, and you have bowel and bladder dysfunction, then this is called chorda equina syndrome. That means complete chorda equina is basically compressed by the protrusion of either the disc or the fracture of the vertebra. Yes?
Doctor, what do you mean by band anesthesia?
Band anesthesia is within a dermatome. You know, so you have dermatomes. So if you have one segment of the spinal cord affected, in that region which it is supplying, there is a band anesthesia, complete loss of all sensations. So, do you understand what is a chorda equina syndrome?
Yes.
Then if there is a protrusion of the vertebra below the spinal cord, where the spinal cord ends, you are going to compress the chorda equina. If there is a complete chorda equina syndrome, you would have backache, bowel and bladder dysfunction, leg numbness and weakness bilaterally, and saddle type of paresthesia. These are characteristic signs of chorda equina syndrome. Okay? Thank you very much.